So some of the other new agents that are along the pipeline of pathway of FDA approval include lutetium.
Yes.
Where do you see lutetium going?
So there are a number of trials that are looking at PSMA-based therapy linked with isotopes in prostate cancer. I think that these are going to be looked at in terms of competition to chemotherapy. There's a randomized trial that was looking at lutetium versus dealer's choice standard of care, such as enzalutamide or abiraterone, in patients who had failed other treatments. I see this moving up earlier because, again, look at the biology. You do need PET scanning to detect the PSMA positive patients. Not all prostate cancer cells make PSMA, particularly the visceral disease that tends to have less PSMA expression. So I mean, the responses have been impressive, 40 to 50% PSA decline rates, objective soft tissue responses. So I do see this being integrated within the armamentarium. Question is, do you combine it with a checkpoint? Do you combine it with other agents? This is, again, going to spawn a whole series of
So you're betting that lutetium is going to get FDA approval?
I'm betting that it's going to get approved,
yeah. You worry about the bone marrow problem of lutetium?
Yeah, I do worry about that over time. We need more long-term data in terms of how the patients will react to it. You know, surprisingly, with radium-223, that's not been a problem, at least as far as the reports from the databases are concerned. You can safely give other treatments such as chemotherapy afterwards, but it does need to be. It is something that needs to be monitored.
Yeah, my one experience, or I've had several experiences, is in people who've had radium. The lutetium is difficult to administer because of bone marrow issues.
Exactly.
So we do have to be aware that you can potentially damage the bone marrow in these patients. So let's try to wrap it up a little bit and think about the big picture. Let's take now the your current plan of treatment for a relatively young, healthy patient who comes in to your clinic with bone pain and high volume disease. Where are you going to take this patient over the next 3 to 7 years?
So a young patient, bone pain, high volume disease, that's a patient I tend to give docetaxel up front with androgen blockade. That's will be my treatment of choice. Then, of course, what do we do at the time they become castrate resistant? All depends upon where their sites of disease are. If they're bone only, if they have no minimal pain, I would tend to give Siptaleucel T right at progression. If they're not bone only, if they're visceral, then I tend to move chemotherapy up front earlier in these patients. The question, of course, is then next generation antiandrogens, how do you integrate those? Same thing, right after CYP-T, I tend to go with Abi or enzalutamide. And of course, we do see some visceral responses with these agents as well. So again, these are useful in this situation. You have to, again, tailor it to the patient. As the course goes on, they may need radium to take care of their bone pain. They may need cabazitaxel to also treat lymph node or visceral metastases. So again, we tailor it based upon the sites of disease, the molecular profile. Again, I'm going to check for MSI. I'm going to be checking for BRCA.
Yep. Well, and another question that comes up often is, right now we're using 2-drug therapy up front. We're using either docetaxel and ADT, or we're using a AR inhibitor and LHRH agonist. Do you think that we're going to see a move to 3-drug therapy up front, and when will that occur?
Well, I think that we have to also keep toxicity in mind. That's got to be the key, because remember, we are treating some patients who are older. I think we're going to start seeing quantum leaps in survival with triplet regimens or multi-drug regimens. That's when we'll start coming to play. But again, we've got to balance this off against side effects and toxicities.
Right. I believe the trial is darolutamide.
Correct.
It's LHRH agonist, darolutamide, and docetaxel. I think darolutamide is the variable. So it'll be LHRH agonist and docetaxel with or without darolutamide. Do you know when that's going to report out?
No, I don't.
Okay. So that will be a practice changer as well.